So you've just heard about anemias. So we're going to talk about iron deficiency, B12, folate deficiencies, and then we'll talk about, just briefly, I'm going to introduce what we do with anemia of chronic disease. We will see that over and over again. I will go into a lot more detail about the drugs when we get to kidneys, because we use those a lot in that in that disease. But a lot of anemia, chronic disease, uses the same drugs, but I'll flesh it out there. So let's start with iron. Why is iron important? What's its two big things? Carry oxygen. What else? This one you may not think so much about. Pardon? Synthesis of stuff. So a lot of enzymes require iron as a cofactor, or it's part of the enzymatic process. Bacteria need iron to grow. So one of the things your body will do is when you get an infection is it will shut down your ability to absorb iron. So in those chronic inflammation, chronic infections, people get iron deficient because they can't get the iron out of storage because the liver will produce a hormone. You'll talk about hepcidin in path like this. We'll talk about it more. It's relatively new, so people are just understanding it and its role in iron homeostasis. Okay, so if we have, so iron to me is like a princess. It has to be delicately handled. Okay, so too much, and what happens? It breaks. Too much is toxic, evil. Too little, what happens if you have too little iron? You get anemic. Okay. So the body does not have any way to get rid of excess iron, right? Okay. So the body has developed an amazing ability to regulate iron. So the gut is an amazing organ. It can absorb almost anything you give it, so good and bad. But with iron, it doesn't let you absorb it. So when we talk about absorption, what exactly does that mean? Where are things moving from to? Especially when you're talking about like we talk about drugs. So it's where? The gut to the circulation. Okay. So we can think of gut as being outside. Start the mouth, go to the end, you're always outside the body. So you got to absorb it to get in the body. So to get in the body, it has to go through intestinal cells, right? Enterocytes. So the enterocytes are key in regulating iron. Okay, you've heard all this before, yes? Okay. So that is very different from most other things that we will see or talk about, especially with drugs, is that those enterocytes are important. So let's look at, these are probably review, I'm just getting your mind back in it. So iron, we have about 4 to 5 milligrams of or grams of iron in the body. Where is most of it? In the red blood cells. Okay. Where else is it? Just look up there, it'll tell you. Where's our storage? Livers, big ones. Muscle, myoglobin. Bone marrow, where we make the red blood cells. So that's a lot of it, is where that is. And then in the blood, we've got serum iron, so that's available iron. What's transferrin? It's a protein that does what? It transfers what? Iron from where to where? From storage to circulation? Storage to wherever it needs to go. Okay. So it could be that it's to the bone marrow or to other cells that are needing it. What's ferritin? And that's a storage protein for iron. Where is it? In the liver. Liver is, most cells have the ability to store iron to some extent, okay? So the enterocytes have ferritin, so they keep it. It's more like a reservoir that the body can tap into whenever it needs it, okay? If you do not use it and those cells slough off daily to some extent, you just lose that iron. So that's iron that never gets absorbed. And that's what's in that loss. So the body's pretty good that whatever you lose in a day, you absorb. So the body, it may enter into those enterocytes, but in terms of getting into circulation, that's regulated. And that matches loss. Now, you can overwhelm the system by having a lot of blood loss, or you take in too much iron and you get toxicity. So you can overwhelm those systems, but if everything's going normally, whatever you lose in a day, you absorb in a day. Okay. All right. I like this still. It's got a lot of good stuff on it. Okay, so iron in the foods that we eat comes as heme iron and non-heme iron. Where does heme iron come from? We talked about this in nutrition. Animal source. So animal source iron is very absorbable. Doesn't really need the gastric acid to convert it. It's fairly well absorbed. What about non-heme iron? Where does it come from? Plant sources. Remember we talked about vegetarians have trouble. If they are strict vegetarians, they will have trouble, or they can get into trouble with iron deficiency. Usually they will take in enough with a variety of foods to stay out of trouble. Non-heme iron has to have acid to be absorbed. Not so much to be absorbed, but to be converted. So acid is really good at helping extract nutrients out of the foods that we eat. Iron, we see it with B12. So when iron gets extracted from food, it is in the ferric form, and that is the most oxidized form of iron, right? Go back and pull Professor Polk's physiology. So this is one where you need to go back and pull in another module. In nutrition, she did these. So this is ferric. This is ferrous. Okay. This is the form we need. Okay, that's what will enter into the cell. Ferric is the most oxidized, so if you put iron in the presence of oxygen, it will eventually move to that form. This is the more reduced form. And this is the one we want. So it's easy to remember, because if we're going to replace iron, we usually replace it with ferrous form, the ferrous state, like ferrous sulfate. Okay. All right. Now, in case we have ferric form available, you've got this enzyme there, that duodenyl cytochrome B. So that is an enzyme that can convert ferric to ferrous. Okay, so that's on those enterocytes. Once it's in the ferrous form, it can move through this portal right here, this DMT1. Okay? So most of the iron that's available in the blood is going to move into those enterocytes. Then what happens to it? Remember? So it forms this pool of iron. Iron is really toxic, and so the body will very quickly put it into a form that will keep it from being toxic. So iron is like the hippies of the 60s, which I know you missed. That's too bad, because it was a good decade. It will quickly tie up that ferric form because they produce free radicals. Okay? And those are toxic. So we'll see when we get to iron overload or iron toxicity in the ER module, is that's one of the big problems with iron overdose, is all those free radicals just destroy. They destroy the liver, the stomach, they get the brain. So we tie it up and we put it into ferritin. Okay. So ferritin is that storage molecule, or a storage form, storage protein for iron. What are the big stimulus? What would make this enterocyte? Now that iron's going to sit there until that cell dies and sloughs off, or the iron is mobilized. So what would make this cell release iron? What would be two big things it would need?
Red blood cell.
You need red blood cells, and we call that process what? Erythropoiesis. And what would be the other thing?
Injury.
Pardon?
Injury.
Not so much injury. Maybe if it was chronic. So it's low iron stores. Those are the number one stimulus for those cells to release iron. Okay. So iron exits through this channel up there called ferropoietin. Ferroportin, like the iron door. It's like Game of Thrones. Okay, so iron gets out here and it enters into the blood, and that's where it joins up with transferrin and is transported throughout the body. So you see this hepcidin right up there that the liver produces. It is a huge regulatory hormone. It regulates the effects of, or the release of iron from those enterocytes. So if iron stores are low, then hepcidin levels are low. Because when hepcidin gets released, it sits on that ferroportin channel, ties it up, and the body will reabsorb it. And so the enterocyte just holds on to the iron. I'm not going to test you over any of this. I'm just trying to get you to remember, bring it all back together, because we did it in different modules. So when you order a serum ferritin, what are you measuring? The amount of iron in the body. Well, how do you get a blood sample and they tell you what iron stores are? If it's all in the cells, how does that work?
You look for hepcidin.
No? You just secrete a little bit of that serum ferritin out. It gets into the serum. And so it is an indirect measure or look at the body stores of iron. If you, what's a total iron, what's a TIBC? What's total iron binding capacity? Remember? So total iron binding capacities tells you the capacity of transferrin to bind iron in the blood. Think of it, the iron goes into the blood, it's got to be bound because it's toxic. So think of the transferrin as being buses. And they've got all these seats, and when the iron comes out, they put them on the bus, but we don't occupy all the seats, do we? Okay. So think of it, instead of total iron binding capacity, it's total iron bus capacity. Okay, maybe that'll help. All right? So, and then we can look at that, that tells us the how much. So in an iron deficiency anemia, what would happen? What would your total iron binding capacity be? It's low. Okay. What about transferrin? Do we get a transferrin saturation? Do we order that? Did you talk about transferrin saturation? You haven't had lab medicine?
No. That's
Oh, sorry. Okay, well, you already know it. You already know. Okay, so what we can do is we can look at how much iron is in the blood, and we can divide it by that total iron binding capacity, and that will give us the transferrin saturation. That also is low in iron deficiency anemia. So if you can remember where all those things are, then the lab medicine will make more sense. Okay, storage, what binds it, and how much of it is bound. You will get those when you are looking at an anemia. Okay. All right, sorry, got ahead of me. Okay, so that's how the body moves iron around. All right. Questions about that? All right, so let's pick up on page 3. So what does an iron deficiency anemia look like? What did Dr. McNeil tell you? Pardon?
Patients typically are short of breath.
Okay, they would come in short. Why are they short of breath? Okay, so their oxygen carrying capacity is reduced. Because why? Why is the iron important? Because it's in what protein? Heme. Okay. But if you're gonna, okay, let's say, what does the lab look like? If you're looking at you get a red blood cell count, what does that look like?
Hemoglobin is low.
Okay, so hemoglobin could be low, what else? What does the red blood cell look like? Small? And they're usually pale, so they're usually less intense. Okay, so they're a microcytic anemia, right? So in terms of who we treat, we're going to treat everybody who has an anemia. But we're also going to treat people whose iron stores are low, but there is no evidence of anemia. So that you can be low in iron. So, and that would tell, what would tell you that? What #1 test would tell you that? The ferritin. So if their serum ferritin levels are low, then their total body iron is low. So even if they don't have an anemia, we're going to treat those 2 people. And then if they have a potential for a nutritional deficiency, this would come up, an example would be in kids. Children that are breastfed or on formula without iron, they have the potential at about 4 or 5 months to become iron deficient. And so we put them on iron drops. So those are who we're going to treat. So the symptoms are listed down there. You mentioned some of them already. People who are iron deficient without anemia, usually their major symptom is fatigue. But the others, depending on the degree of the anemia, headache, weakness, decreased exercise tolerance, irritability, depression. In children, it's really important to identify this because of developmental delays. Other symptoms, pica and pagophagia. You talked about that? What's pica? It's not necessarily dirt. It can be dirt. What does pica mean?
Craving non-food.
Eating something is not necessarily food. So dirt is one. I had a lady, I had a patient I took care of at family medicine, and she was a dirt eater. She came in one day and she was having multiple low blood sugars. And so the more I talked to her, eventually I figured out what she was doing is she'd go in the backyard, she would dig up dirt, bring it in, she'd microwave it, and then she ate it. Well, it had no nutritional value. Go and look at dirt eaters on Google, because there is a group of people, there's a groups that think that eating dirt is a good thing. So she wasn't taking any calories, but she took her medicine, so she got low. So that was one of the ways I figured that out. So, okay, so dirt is one. What else is pica? Ice. What else?
Stones.
What? Stones. Haven't heard that one, but okay. What's another common one?
Hair.
Chalk. Okay, paint. So paint chips. So we worry about that. That's why we got rid of the lead in paint. Pardon?
Is that craving, or is that just like?
Another type is cornstarch. I had a lady one time, she would eat a box of, you know, who makes that? Armor? Yellow. Yeah, she would eat about a box a day of cornstarch. Okay. The other would be beet urea, so reddish urine after eating beets, and restless leg syndrome. If you eat beets, you will get red. What they're saying is it's the same kind of symptom, right?
Oh, they don't need to eat beets.
No. So iron deficiency without anemia. Symptoms, fatigue, #1, reduced exercise tolerance. Benefits of replacing iron stores, usually you see an improvement in these things. Fatigue, your athletic performance will go up, sleep will get better, the fingernails won't break. It's important to guys, so have to watch that. Okay, so sources of iron deficiency and iron deficiency anemia. Dietary deficiency, more likely to be in kids. When you look at the foods that have iron in it, if you are eating at least a balanced or rounded diet with many different variety of foods out of different groups, you're usually going to get enough iron. We don't need a whole lot, so we usually can meet it with dietary needs. But with kids, especially if they are drinking cow's milk, unmodified cow's milk, if you've got folks who are into that, breast milk, formula not supplemented with iron. Other is impaired absorption. So this would be in your more chronic inflammatory states like Crohn's or ulcerative colitis. Gastric bypass. Remember we talked about this in bariatric surgery. Where is most of the iron absorbed? And it's in the duodenum. So remember those big, like the Roux-en-Y and the other one, the jejunal switch. That one is, those are the two big ones that will cause an iron deficient, or can be related to an iron deficiency anemia. Also the gastric sleeve, because when we cut out most of the stomach, what cells are we removing? Parietal cells. So those parietal cells are part of the acid-producing function of the stomach. So you've got a small pouch, not a lot of acid, you can't convert as much ferric to ferrous, so you can get an iron deficiency anemia associated with them as well. Pregnancy, we'll talk about this when we get to OBGYN, but increased demand. So mothers increase their blood volume by about 50%. It goes up quite a bit. You've also got that fetal placental unit that is very vascular, and the baby needs that as well. So you've got a lot of demand for iron. So in women who have multiple pregnancies are at high risk. Women who have their pregnancies very close together, if there's not a recovery or an attention given to the iron status during that time, can get iron deficient in the next pregnancy. Bleeding is probably the #1 cause in adults. So a couple of things. So if it's a bleed from a known source, let's say they're taking non-steroidals or they develop an ulcer. What else did I put down there? Women. Normal menstruation will not lead to iron deficiency anemia, but if women have very heavy flows, women who have uterine fibroids that bleed a lot, those, when they're losing more than normal, those women are at risk. Okay, so those are known causes. It's the unknown in adults that you need to work up for malignancies, or especially a colon cancer. So bleeding of unknown cause would need to be worked up. Populations at risk. So we've talked about some of these already. Infants, young children, adolescents are growing. Their diet is not always the best. Pregnancy we talked about. Older adults may not eat as well, may not produce acid, may have, we talked about pernicious anemia. Okay, so they're more at risk for inflammatory bowel disease. We talked about that in terms of absorption. When inflammation goes up, if you have an increase in inflammation, you have an increase in hepcidin. So what does that do? What did I tell you that did? Hepcidin does what? Look at your picture. It sits on that ferroportin, and it doesn't allow the iron to come out. So inflammatory, you may have the iron in those cells, but you can't get it out. Okay, so that's why inflammation, chronic inflammatory, they can't release the irons from stored. Interestingly, obesity does the same thing. So obesity also increases hepcidin. Half of people who go for bariatric surgery are already iron deficient. Okay? And a lot of it's thought to be due to that obesity. So the nutritional status of somebody doesn't always necessarily tell you or indicate if they're really iron deficient. Things that affect the stomach, like Helicobacter, gastritis, chronic kidney disease, that's a disease of chronic disease or disease of anemia of chronic disease, sorry. Cancers, myeloproliferative syndromes, heart failure, pre-op patients, especially if they're not in good shape prior to a big stress like that, and then athletes.
Why athletes?
You know, I don't know. Hannah's going to tell us.
You don't eat very good food when you're on the road.
You don't eat very good food when you're on the road.
No, I had actually a teammate that we were working out, and she like went pale, like passed out, and she was super low on iron. I mean, like all of us girls were probably super low on iron. For basketball.
I think there's other mechanisms. Let me look there. Maybe food related. I remember Dylan last year. He was in the class ahead of you, and he is a cross-country runner. He said the same thing. I'm gonna have to remember. He told me the.
Could it be a combo with food and the increased oxygen demand of training so many times a day, so many times a week than the average person?
I wonder if it's inflammatory. You're constantly causing.
State of inflammation, high demand for oxygen.
Yeah. So I'm wondering if that is. Okay. Very good. Okay. So the goals, if we are treating iron deficiency anemias, we want to replenish the stores. It's easy to get their hemoglobin up, okay? We can do that within a month, a couple of weeks. They'll feel better in a few days as you start treating them. But it's the stores that take a long time, so it can take months to replace and replenish those stores depending on how deficient they are. We want to improve their symptoms. We want to treat the underlying cause, and there will be one. Okay, so we talked about the indications, the anemia, the iron deficiency without anemia, and then nutritional deficiencies. So treatment is based on diet. We never do diet alone, and then it's the replacement with iron, either orally or IV. I didn't put that in that section, but you can add that. So we've got two different routes that we can go. Okay, so looking at the diet. So there's a picture for you of the different foods. So you see it comes in lots of different foods. Meats, seafoods, vegetables, fruits, legumes. The other foods up there, peanut butter, nuts, cereals, breads. We fortify foods and cereals with iron. So there's lots of different availability. So getting people to eat a wide variety is good. Let's see, so I talked about heme and non-heme iron in there for you. Note that in the middle, orange juice will greatly increase absorption of iron. So when we have people take iron, we usually want them to do it on an empty stomach, and we would like them to take it with some food that has high ascorbic acid. So orange juice, easy. It's too hard on the stomach, then meat could also be substituted. You want to stay away from teas and coffees because they tend to bind up the iron and don't make it as available. If your patients can't tolerate iron on an empty stomach, they can take it with food, but know that the absorption is greatly affected. So I'm going to give you some ways that you can get around that or give people options to help. Okay, page 6. So oral iron therapy. Iron is inexpensive. It's cheap to treat. Most of these products are over the counter. So that might be one thing to keep in mind is that people may treat themselves. Treating somebody who doesn't have deficient iron stores and is not iron, doesn't have an anemia, there is no value in that. unless you're looking at a woman who's getting ready to become pregnant or is breastfeeding. All iron products are equally effective. They are different in terms of the salt, and we'll talk about that in a minute. Notice that I put down there are slow release formulations and sustained release formulations. And those were developed to try to get around the stomach problems that people were having, because it's a huge impact on adherence. Getting people to adhere to iron therapy is hard, because it's hard on the stomach, makes them constipated, they feel sick. So it's not a very well tolerated drug or replacement. So these sustained release products came about. Well, the problem with them is sustained release is built usually to get around the stomach, so that you can get the drug intact to the intestines and then let it dissolve. Well, the pH is very different in the intestines, small intestines is in the stomach, and so they are useless. Do not use them. Don't recommend them. If patients are on them, switch them. So don't use them. Use the ferrous form. That's the best. You can use any of the salts. I prefer ferrous sulfate, but you can look at the others. They will differ by the elemental iron in them. So if you look down at that chart, ferrous sulfate is about 20 to 30%. I usually go with the 20%. But formulations will differ slightly by the manufacturer. But you'll see that range given in the literature of 20 to 30%. So if the dose is 325 milligrams, that's a 5-grain tablet, you'll see that the ferrous or the iron content is about 64 milligrams. That one you must know, so star it. Ferrous fumarate has a lot more iron in it. A lot of people don't use it because more people get GI symptoms from it. It's got more iron. Ferrous gluconate, a lot of people like to go to it, but has very little iron, 11%. So you got to keep that in mind, is that if you switch to a salt that has lower elemental iron content, you have to get more of it. Okay? So I like ferrous sulfate, it's kind of in the middle. There are liquid iron preps. Some people use the liquid preps as a way to start. They can start low and they can titrate. There is one study that looked at least in kids, that polysaccharide iron complex versus ferrous sulfate, and found that it did not increase hemoglobin to the same extent as ferrous sulfate did. So you just kind of have to keep that in mind. So I'm not recommending any of those over the others, but keep the liquids in mind as a potential if you've got patients who can't tolerate the tablets.
I have a quick question. Why does patients normally do better on IV iron than they do like taking tablets? And then
Okay, we'll get there.
You're getting it, okay.
Yep, we'll get there. Okay, so dosing and administration recommendations have changed. So what I've given you there is the conventional recommendations that have been around for 30, 40, 50 years. Okay? So usually when we were replacing iron, we would give them iron every day, 2 to 3 times a day, because iron is, the more you give, the less gets absorbed. So we break it up into 3 different doses a day, have them take it in between meals or before meals, and with the hopes that we can get enough iron absorbed to correct the underlying problem. The adherence with that approach is very low. It's very hard on the stomach. I told you people don't do well with 3 times a day dosing. So BID dosing is better. There has been small studies done looking at alternative approaches. They've looked at once daily and every other day iron to see what happens. So if you look on the next page, I'm giving you, this came out in the fall of last year. So there's evidence that having people take iron every other day actually results in a greater percent of that being absorbed. And they think it's related to this pepsodent. They think that the more iron you give at one time, you increase this hormone and you decrease the fractional amount of iron that gets absorbed. The studies are small. The ones that I read that are in adults were done mostly in women, and they were done in women who were iron deficient but did not have anemia. And they did 3 times a week. So usually when we do 3 times a week or every other day, it's best to do Monday, Wednesday, Friday. Every other day is a mess unless you have an OCD patient who will just keep track of it. So to me, Monday, Wednesday, Friday are better. Yes?
Sometimes the GI would tell them to take them on the odd days of the month.
You can try that. You can do that.
Yeah. Look at the calendar and see the day.
That's right. For people who don't know what day it is, then that might become a barrier. But so I tend to use the Monday, Wednesday, Friday. So the doses that were used were low doses. They were using 40, 80 milligrams a day. I can never nail down if they were using, that were referring to elemental iron or the salt. But I think, after I looked at it a couple of times, I think they're referring to elemental iron. So if you look back at ferrous sulfate, flip back to that table, look at it. So how many tablets would you have to give to get that amount? 1. So that would be 1 tablet every other day. Okay? And what they found is that you got a better increase. Actually the hemoglobin in stores went up higher in the same amount of time compared to daily. So it is hard to find recommendations that lay that out like that. But I'll tell you from just watching patients over time, it makes sense. They can't tolerate multiple in a day. So if they can go to and you've got good adherence with the every other day, might be something to keep in mind. I have found people do better with once a day, just from remembering it. So those are things to keep in mind. With older adults, I gave you an example of what I read one group did. They used liquid ferrous sulfate and they mixed it with 2 ounces of orange juice, which gave the patients 88 milligrams of elemental iron a day. You could use vitamin C tablets as well. So they're cheap and they don't add sugar. So if you have a diabetic and you're not wanting them to drink juice, or they can't tolerate the juice, they can take it with a vitamin C tablet. And you'll find some products, iron over the counter, that have vitamin C as part of their ingredients. Food interferes with iron, so that's the second time I've said it. So we want them to take it on an empty stomach. Very important, keep iron out of the reach of children. Most of these should come with safety caps. Warn patients, especially if you're in an adult practice or if you're in a pediatric practice, iron is lethal. It's and it doesn't take much in a kid. And the problem is that it does all of its toxicity before you ever can realize it. So they can be quite advanced in the toxicity before you discover it. So it takes about 12 hours for it to exert its effects on the liver, and then it can be really problematic. So keeping iron away from kids, very important. Let's see. So down to the bottom, I think I've talked about the others. So bioavailability and absorption of iron. So separating iron out from calcium. So if they're taking a supplement like Tums, let's say they take it because it upsets their stomach. Well, it binds the drug up. It binds up the mineral. Calcium supplements, antacids, fiber, tea, coffee, eggs. Those are the big ones. So in your practice, what do? You don't have to remember all this. You make a handout and you hand it to the patient. Avoid these foods. Don't take it with these supplements. That way they can go home, they can tack it up on the refrigerator, and every time they look at it, they'll remember you and they'll remember what to do. My diabetic patients used to tell me that whenever they opened the freezer and they saw their ice cream, my face would float up in front of them and say, stay away from that. Okay. You may not realize that their foods have a lot of calcium in it. So here are some foods that have calcium. Dark green vegetables, one that's not on here is kale because it was put out before the kale craze came along. So dark green leafy vegetables have a lot of calcium, can also bind iron as well. Let's see, we talked about, okay, talked about all this. Let's go to the next page, page 9, strategies to improve tolerability. So one thing we just talked about, reduce the dose or increase the interval. So going to every other day, going to once a day dosing will help. Making dietary modifications. Don't take the iron with food or milk because it'll reduce absorption. Switching formulations, you could go to a lower elemental iron, but then you're going to have to give more of it. Okay, back to that ferrous gluconate, very small amount of iron per tablet, you're going to have to give more. One thing I have found helpful is to start with the liquid iron and move it up to the dose that the person can tolerate. I have them diluted in water and drink it. That has helped with some patients. Consider going to IV iron. We're going to talk about it in a section by its own. And that's one of the indications for IV iron is when you have someone who just can't comply or tolerate oral iron. Yes?
Are there not issues with taste with the liquid? I guess it's not that, I've never had it, but.
Well, I mean, it doesn't taste great, but it's not terrible, especially if you dilute it. Adverse reactions, adverse effects, just with normal dosing, it's mostly GI. This is at the higher doses that I told you about before, okay? If you look down at that third bullet, they're dose related. It'll make their poop look darker, constipation or diarrhea, nausea and vomiting. So that's why a lot of people just can't tolerate it. Others, metallic taste, dyspepsia, increase in gas, green or black tarry stools, that really freaks people out. You need to warn them. Can stain clothing if they have fecal incontinence, all those fun things. The last one is stool softeners may be prescribed for constipation. You will see that as a recommendation is largely ineffective. Stool softeners, unless you use fairly high doses with a lot of water, they really aren't that effective. So I think that when you go down to that once a day or every other day, the side effects are minimal, if any, and the effects, especially constipation, is greatly reduced. Okay, so these drugs do what? They decrease acid in the stomach. They raise the pH. So they interfere with the conversion of iron from ferric to ferrous form. So we don't want them taking them at the same time. They could take them at different times, but not at the same time. Some women use these as their calcium replacement or calcium supplement, so warning them about that as well. Others are listed down there, tetracycline, doxycycline, that drug loves to bind up things. So separating those out, those would be episodic. The H2 antagonists like ranitidine and famotidine are also acid suppressants, gastric acid suppressants. The proton pump inhibitors, omeprazole is one that's over the counter that people, and see a lot of these are over the counter. So one is to keep it in mind so that if the patient comes in, what you're doing is ineffective, is knowing these things so you can ask and get a good history. Cholestyramine is a bile acid sequestrant. You won't see it very often, but there are other drugs in that category. They're not used very often anymore for to lower cholesterol, but they may be used in liver patients or if people have intense pruritus because they'll bind up bile acids and decrease those symptoms. So they're a binder. They bind whatever's around them, and so they'll bind up any drug you put in the stomach with it. So one of the less likely that you're running into. So how long do you treat? Okay, so your hemoglobin will, I've got at the end of the iron section, I've got your monitoring parameters, but hemoglobin will rise fairly within 1 to 2 weeks, and you'll see good response usually within a month. So to treat their anemia usually can resolve in 6 to 8 weeks. Their stores will take time. So some people recommend treat a month beyond when all indices are normalized, or keep in mind that could be anywhere from 3 to 6 months depending on how deficient they are. And what would you order in order to tell? So what are you going to be looking at? CBC, which will tell you what? Hemoglobin, hematocrit. You can just look at hemoglobin. What else?
And then order an iron study to make sure they're ferritin.
Okay, so you could do a serum iron. What else would you do for stores? Ferritin. Okay, you're going to look at the red blood cells?
And TFDCs?
You can look at the TIBC, but the ferritin will be a big one for you. And you're also going to look at the red blood cells to see if they normalize.
So if you are on like an anemic pill, ferritin, so you're saying that once it's up, it should stay up? Like you shouldn't have to keep
If you've
prescribing?
replaced stores, yes, but you're also going to be looking at what is the cause, what led to this, and you're going to be correcting it as well. Is it their diet? Is it multiple pregnancies? Place the stores and they're not going to get pregnant anymore, they should be fine. Yeah, or is it heavy blood flow, menstrual flow? Okay, those ways to take care of that with drugs or surgery or modifying the menstrual cycle. Cancers would be another. So you're going to be looking for a reason for these to happen. So also treating underlying cause.
You're okay to just stop it?
Yes, yes, yes. You would just stop it at that point for most people. Reasons for treatment failure: non-adherence. How many times have you heard me say that already? If you do not assess adherence, you will miss a lot of the reasons why your patients aren't responding like you thought they would. Most of them are not going to do what you tell them to do. They're not. Some will, but the majority are going to make some modification based on what they believe you are up to, what they believe the drug, their belief in disease treatment, lots of different reasons. What other people are saying in their ear. So it's a battle. Strategies to improve tolerability. I think most of these, this is just a repeat. So reducing the dose we talked about, switching the interval, going to liquid if you need to start even lower and titrate up, or switching to IV iron. Okay? So here are the advantages and disadvantages of oral versus IV. Oral is going to help most people, especially mild anemias. These do not need an IV iron. Oral iron, low risk, very low cost. For IV iron, it's very effective. It gets around the GI side effects. It replaces stores and treats the anemia in very short order. It doesn't take that long. Compliance is assured because you have to go into a doctor's office and have it administered there. And no GI effects. So what are the disadvantages of oral iron? Well, the GI side effects are a problem, and especially with higher doses. Adherence may be low. We don't use the word compliance anymore, we use adherence. If they have ongoing blood loss, it will be hard to cure it. Okay? If the blood loss is exceeding what you're replacing, you're never going to win. So you've got to figure out where the blood loss is coming from and address it. And so IV iron is usually better in that situation. It requires months of people taking a drug, so adherence goes down with that. Disadvantages with the IV iron: has to be given IV, has to be monitored, has the potential for serious allergic reactions even though they are very low. But you have to have equipment and people who are trained to resuscitate or to run an ACLS protocol if needed, and they are costly. But for moderate to severe anemias, they may be the better choice. Okay, so let's stop there with, before we do parenteral iron, take a break and then we'll come back. So about 5 after we'll start back.
No, I don't know. Wait, what is it? Don't really get it all.
I've never heard of this. What's the?
It's just word. Oh, no, I did that. I like changed it to a PDF so you can know what it's saying.
Thanks, though.
Yeah.
Well,
Whatever. I'll still learn it. It's still there.
My friend told us about a little girl who's been diagnosed with ADHD, and
She's diagnosed with what?
You don't have any trash at the front.
so I'm can't really make sense of all this stuff on the pocket. So how we started giving it to her in the morning, and she's falling asleep at school.
What's the disease?
ADHD.
Sorry, you said it so fast, I just
Oh.
could not. Okay,
Okay.
got it.
Yes, is
Why
that?
are they using that instead of?
I don't know. So I
Okay,
just
it
meant
is
that.
an alternative, it's a second line option. Yes, that's true.
Do you know what the first one is, so I can kind of because they.
Oh, yeah, like,
Okay.
yeah.
This girl's calling